So why is HPV vaccination approved from 9 to 45 years in India, whereas in many countries like USA, it's approved from 9 to 26 years?
In many countries, the QHPV is approved from 9 to 26 years. In some countries, the approval is sought up to 45 years based on the efficacy trials named Future 3 trials, in which the efficacy for the age group 24 to 45 was shown to be around 90%, 89 to be precise. Thus, based on the results of Future 3 studies, adult woman indication AWI was granted. Currently, the QHPV is approved in 135 countries and in 54 countries for the age group of 9 to 45. That is AWI. India, Canada, Australia, New Zealand are examples of some countries where it is approved from 9 to 45 years. In countries like USA, vaccines are given through either public or private insurer, which compels them to give it in the best recommended age, that is the primary schedule, and in catch-up vaccination schedule for those missed during primary vaccination age. Also, cost effectiveness would be more if it is given in age when you would get better immune response and ultimately clinical benefits.
Now the next question we have is, what is the maximum duration of protection that can be given with quadrivalent HPV? Our patients ask us, will we be protected against cervical cancer forever?
The quadrivalent HPV was developed and launched in the year 2006. Mathematical models have predicted that is antibody titers will last up to 32 years upon completion of third dose. In addition, many subjects from Nordic countries, that is Denmark, Norway, Iceland and Sweden, are being followed up from 2003 till now. This data is called as Nordic data or LTFU, long-term follow-up. The 14-year findings of this Nordic data was presented at Eurogin in 2018 and no breakthrough case was found. As of June 2020, the Nordic data is published. That is long-term data from age 9 to 26 years. That is Nordic data. 14 years, no breakthrough, 100% effectiveness. Long-term data from age 24 to 45 years, 10 years, no breakthrough.
Now we go on to the next question. We know what happens if someone misses, what to do in such circumstances.
There are 3 doses of quadrivalent HPV will be administered in the following schedule. The first dose 0 months, second dose 2 months, third dose 6 months. The alternative schedule, the first dose 0 month, second dose instead of 2 months you can give 1 month, and third dose instead of 6 months you can give 4 months. As long as all 3 doses are completed in 1 year, it is fine. But it is best to complete the schedule 0, 2 and 6. Based on the post hoc analysis, comparable efficacy will get if minimum gap between 1 to 2 second dose is 1 month, and that of between second and third dose is at least 3 months. For girls below 9 to 14 years, 2 doses of 6 months apart is the schedule. If they miss the schedule, then you have to administer the 3 doses. Although approved in many countries, this vaccine is not approved for usage in men or boys in India as of now.
Now, going on to the next question, when do we vaccinate? What is the age group and which age group is the best for vaccination?
HPV infection is sexually transmitted and is usually acquired within the first few years following sexual debut. Ideally, therefore, vaccines should be given before any risk of exposure to HPV. Age from 9 years till 15 or 16 years. Also, it is important to remember that antibody response to vaccine is much higher in younger age group, Thus, young age 9 to 15 or 17 is the best age to vaccinate. However, if one cannot vaccinate young and adolescent girls due to any reason, then one must vaccinate at the next available opportunity, as the window period to vaccinate is long, that is 9 to 45 years. Another opportunity for vaccination is postpartum period, as quadrivalent HPV is found to be safe in this period. There are studies which have indicated that women are also more receptive to the idea of into their OPGN for vaccination. The whole idea is to improve practice patterns and every opportunity to recommend HPV vaccines caused by HPV. In Safe Motherhood Program of India, this vaccination also is included.
Now we have the next question, which was asked as, what if a woman becomes pregnant after taking the vaccine? Or she was already pregnant when she had taken the vaccine? What to do then?
Vaccination should not be done during pregnancy. The reason is that there are not enough well-controlled studies done in humans for pregnancy, as getting approvals and subjects for studies during pregnancy is difficult. However, if someone was pregnant, vaccination does happen, there is no need for termination of pregnancy, as the studies have indicated that vaccines do not cause any risk of additional fetal malformations or abortions in any harm. However, as soon as the pregnancy is confirmed, the remaining dose should be deferred and can be administered after the delivery.
Now, going on to the next question. Is there any protection of this vaccination against genital warts? And hardly do we see any cases of genital warts?
The prevalence of genital warts, as done by a study in India, was around 1%. Another study done in Denmark with a follow-up of 30 years, involving around 50,000 subjects, indicate that diagnosis of genital warts was strongly related to anal, vulvar, vaginal, cervical, and subsites of head and neck cancer with confirmed HPV association. Hence, if one can prevent genital wart, then one must.
With that, we come on to the next question. Sometimes a patient says to me that I do screening regularly. But is screening better or more cost effective than vaccination, or is vaccination a better tool?
Ideally, both screening and vaccination should go hand in hand. Just because you are screened does not mean that you don't require vaccination, and vice versa. Also, there is no need of doing screening just prior to vaccination. Thus, it is best to vaccinate as well as follow the guidelines for screening of that particular country.
Go on to the next question. Now we understand that vaccination is good, but development of cervical cancer takes almost 10 to 15 years. It's quite long. Then how do we know that if the vaccine is going to prevent cancer in, say, a lady who has got vaccinated just a year back?
Yeah, since the vaccine was launched in 2006, many countries have adapted it in their NIP, that is National Immunization Program. And we are beginning to get good real-world effectiveness data from such countries, ex-Australia, New Zealand, Denmark, Sweden, etc. One recent interesting data from Australia, which is one of the first countries to include quadrivalent HPV in their National Immunization Program, indicates with data from a state-based cervical screening register, we have shown a decrease in high-grade cervical abnormalities in young women after the implementation of the vaccination program. Also, since genital wart takes less time to develop as compared to cancer, there has been a substantial reduction in genital warts in both women and men. Similarly, we are encouraging data from other countries too.
Now we have a next question. What about cross protection? We have heard that bivalent offers cross protection against other HPV serotypes, namely 31, 33, and 45. Whereas quadrivalent HPV does not actually provide that protection, is it?
It is worthwhile to remember that both quadrivalent HPV and bivalent HPV contains HPV 16 and 18, which are the high risk types. That is, these are associated with cancer causation, especially cervical cancer. Globally, 16 and 18 are responsible for causing 70% of all cervical cancer cases, whereas in India, they are responsible for causing around 82% of the cases. Hence, we should be focusing more on the serotypes, which are by far predominantly responsible for causing most of the cancers, that is 16 and 18. As far as protection against other serotypes is concerned, the cross protection with both the vaccines is inconsistent and short-lived. Direct protection and long-term follow-up are the best indications for prediction of Nordic data with quadrivalent HPV rather than cross protection. Merck has launched Gardasil 9 HPV serotypes 6, 11, 16, 18, 31, 33, 45, 52, and 58. This will take care of more than 90% of the HPV responsible for cancer. However, Gardasil 9 is as of now not available in India.
Now we have the next question. Is this vaccine safe? Actually, we have read in internet and media about stories going around that this vaccine is not so safe. Should I be concerned? Because I'm a female doctor myself. Should I be concerned?
There is no denying that the vaccines have attracted a bit of negative publicity. However, it is important to remember that many international bodies like USCDC, that is Center for Disease Control in the US, WHO, EMA, European Medicines Agency, have conclusively said that vaccine is safe. In almost all the cases, the complaint filed due to or against the vaccine has not been found to be associated with vaccine. That is, the casualty could not be attributed to a vaccine. In addition, surveillance is ongoing and the vaccines will continue to be monitored. Academic have recommended this vaccine, and one must not pay heed to online rumors.
That's true, sir. That's
we can have rumors, but not rumors.
That is true. That's true. So coming on to the next question, is it true that antibody titers with quadrivalent HPV falls after some time and we might need a booster?
It is important to note that both quadrivalent and bivalent HPV induce antibodies, and after some years that antibody levels fall. But it is equally important to note that this quantitative estimation of fall in antibodies has no effect as far as protection against HPV is concerned, because the level of antibodies required to provide protection against HPV is not defined. Thus, currently, there is no need for any booster. In addition, instead of going for indirect markers like antibody titers, the best indication for protection is the clinical endpoints, that is, absence of disease. That is where the current Nordic data of 14 years becomes important.
So going on to the next question, we recommend the vaccination to almost everyone, yet very few come forward for the vaccination. What should I do actually? What can we do?
Studies have demonstrated that the strongest recommendation comes from a physician, OPGN, or a family doctor. Some strategies are strong recommendation adolescent vaccines to parents of your 9-year and older patient. Parents more than anyone else when it comes to immunization. So strategy is to talk to the parents. Use every opportunity to vaccinate your adolescent patient. Ask about vaccination status when they come in for sick visits, when they come for fever, diarrhea, asthma. Ask about vaccines. Use vaccine on postpartum period, post-delivery, if the woman has not received HPV vaccine earlier. Patient reminder and recall systems such as automated postcards, phone calls, WhatsApp message, text message are effective tools for increasing office visits. educate parents about the disease that can be prevented. The deadful disease can be prevented by vaccines, and parents may know very little about pertussis, meningococcal disease, or HPV. Implement standing orders policies so that patients can receive vaccines without a physician examination or individual physician order. All branches of medical science must come forward for promoting HPV vaccination.
Should healthcare workers and doctors also take this pneumococcal and the influenza vaccination during this COVID pandemic also?
Yes, everyone should be protected as per their age and indication. If your patient, especially healthcare worker, if they are more than 65 years, they should have flu vaccination every year, pneumococcal vaccine. Healthcare worker, they have to have flu vaccine, MMR vaccine, hepatitis B vaccine, Tdap or TD, or herpes zoster vaccine. If their patient is diabetes, they have coronary artery disease, COPD, they should have flu vaccine, pneumococcal vaccine, and hepatitis B vaccine. If they are pregnant, definitely they should have flu vaccine and Tdap vaccine. If they are college student, the hostel especially, they have to take meningococcal and then MMR and typhoid vaccine.
Now, what will be the pneumococcal vaccination schedule for a person who is more than 50 years old, healthcare provider?
As per the latest ACIP, that is Advisory Committee on Vaccination and Immunization Practices 2019 guidelines, if there is no underlying medical condition, that is the person is healthy, below age of 19 to 64 years, no pneumococcal vaccine is recommended.
Now, going on to a third and almost the last question. So, what is the relevance of pneumococcal vaccination during this COVID pandemic times?
As per the NFID, that is National Foundation for Infectious Disease, although there is no vaccine available to prevent COVID-19 at this time, of course, now it is available. See, when I wrote this article, it was not available. Now a lot of Covishield is available, Covaxin available, Sputnik is going to be available. So many vaccines are available. Even though you give COVID-19 vaccine, you also should ensure that other vaccinations are up to date, including you should have influenza vaccine, pneumococcal vaccine. This will help to reduce the pressure on healthcare system by reducing vaccine preventable disease. Physicians of today must discuss adult vaccination, which is a neglected subject, with their patients. There are many studies which have proved the efficacy of these vaccines in reducing mortality. For example, meningococcal vaccine may be given to inmates of prisons, crowded hostels, to reduce mortality. When people go for Hajj in the prison, jail and all, there are a lot of crowds, so meningococcal can be indicated. Similarly, people going for trekking or jungle safari must take typhoid vaccine.